syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hello. We are gathered here for the next episode of TMD Demystified live stream. I am Tony Urbanek. Today we are going to go over a couple interesting things that have occurred about TMD in my experience. In a few minutes, we'll talk about my experience with the National Academy of Sciences, Engineering, and Medicine, and their interest in solving the problem of TMD. And I may even mention one of the better known organizations and websites, TMJ Association, whose purpose is to generate interest in the solution for TMD. But for the first few minutes, I wanted to go over, for those who may be watching or those who may be interested in the most prevalent, prominent, and successful non-surgical treatment of TMD, which I have talked about extensively in podcasts and blog presentations, articles that I've written, 180 blog articles, 250 podcasts published on YouTube and Dental Town. But today I just wanted to go over a few basic things for any new viewers that might be interested or available. Today's date is April the 2nd, 2026. And I just got back to the studio here not 10 minutes ago from attending a interested group and a lecture done at Vanderbilt University on aspects of temporomandibular joint surgery. As those of you who watch other podcasts may know, I am an oral and maxillofacial surgeon trained at Vanderbilt, double degree oral and maxillofacial surgeons with academic training in cell biology and anatomy. And the lecture series was on facial reconstruction, not temporomandibular joint, but I actually sat next to a very young resident at Vanderbilt who I had not met previously. And he introduced himself and wanted to tell me that he had watched one or more of my lectures on YouTube about temporomandibular joint. I was quite amazed that a young oral maxillofacial surgeon who was interested in learning about surgery, who had actually viewed my presentations and the information I have to share about non-surgical treatment of TMD. As you know, I did temporomandibular joint surgery for the first 36 years of my 50-year career, 2,000 cases, and decided that TMD was not going to be ultimately served well by doing surgery on the joint, and that I needed to find out if there was a better way, and did the research, and here we are. 15 years later, there is a increasing number of doctors, both oral maxillofacial surgeons, general dentists, and other dental specialists, who agree with me that a non-surgical treatment which unloads the temporomandibular joint with a protocol is the most successful method of treating temporomandibular joint surgery using a very simple device that separates the posterior teeth according to a protocol. Protocol is just as important as the device itself. You have to know how to use it. You have to know how not to use it. You have to know when to use it. You have to know when not to use it. You have to be able to instruct the patient as how to use it correctly. But if you do, you will have exemplary, especially successful experience with it. We have an independent university study done through Middle Tennessee State University based on over 3,000 temporomandibular joint cases, which show the success rate of the device and protocol itself depending on how you frame the statistics. This is a statistical study. How you frame the statistics, success rate between 85 and 95%. In any case, today I wanted to just go over briefly while we wait for anyone to arrive and anyone who wants to ask any questions. Usually it's my protocol to basically talk about the problem one way or another, discuss aspects of the problem itself and the way to treat it. We can talk about how patients respond or not respond to it. And then if answer any questions, and then if any questions come up, we'll just call it a day. But today I just wanted to share, first of all, this diagram again that we had talked about previously, but really is the explanation of what temporomandibular joint symptoms are all about. I just read an article, a published article, that talked about other practitioners, other researchers' point of view, that temporomandibular joint disorder is multiple disorders. And I have spoken on that many, many, many times. It is my position, and I can prove it statistically, that TMD is a single disorder. The disorder is chronic inflammation within the temporomandibular joint. That is the disorder. But I just read a paper that commented and talked about actually TMD, temporomandibular joint disorder, being 30 separate disorders. And it took my breath away. I knew that the number had ratcheted up, increased into, some practitioners certainly call it multiple disorders, but in the range of 8 to 10. And now I'm reading a paper and a comment that they think that it's 30 separate disorders, these disparate symptoms, multiple disparate symptoms of frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, which is that fullness feeling in your ear, dizziness/vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. We can also go into discussions about eye problems, visual disturbances, aura associated with visual disturbances. We are unlocking and observing multiple patients with TMD, chronic inflammation within the temporomandibular joint, who also have visual disturbances, which is the separating line between migraine headaches and any other kind of facial or head pain, has been limited in the most descriptive term that separates migraine headaches is the aura or visual disturbances. But we are also uncovering, and I'm not ready to say that visual disturbances don't separate migraines, but what we are finding out that patients with temporomandibular joint inflammation, chronic inflammation, and many of the other symptoms, and have been diagnosed with migraine headaches, the aura goes away along with their headaches when you decrease the inflammation within the temporomandibular joint. And the slide that I put up here is a diagram that I will go over again that I bring out because it really does explain the painful symptoms associated with TMD based on a single cause, the single cause being chronic inflammation. I hope you can see my little arrow here on this chart. I can put it up on the chart behind me, but I find that I think most of the time people can see it better when I just share the slide on the screen rather than go to the side camera. But let me go through what this slide depicts carefully, both for the doctors who may be watching and any patients who may be watching, because I know obviously both doctors and patients watch my podcast, and they have watched and responded to the live stream that we do every Saturday, which we're doing right now. So when you get chronic inflammation within the temporomandibular joint due to damage to the joint becomes damaged like any other joint in the body by overuse. Joint damage is caused by overuse of a joint. And in the temporomandibular joint, the overuse can be caused by bruxism, clenching or grinding over a long period of time, acute trauma of various kinds to the face and the jaws, acute trauma, auto accidents, 4x4s off the back of a pickup truck, athletic accidents, for the males, boxing accidents, football accidents, for the females, auto accidents with whiplash injuries. And then the third category that causes damage to the temporomandibular joint are what I've spoken on many times is functional malocclusion. Bites, bad bites, functional malocclusions that are so bad that the bite itself overloads the joint just because you're trying to chew. And the bite doesn't work well enough that you overload the joint when you just do normal types of function with your jaw. So you now have damaged the joint, chronic inflammation then occurs. First, you get regular old inflammation trying to heal, and chronic inflammation, when it doesn't heal over a rather short period of time, the normal cellular inflammatory cells and exudates change into characteristics that are chronic inflammation. And that chronic inflammation will send a autonomic nervous system through the sympathetic portion, and that is what this diagram shows. Through the nervous system sympathetic portion to the brain stem. Now, this diagram shows the different nuclei that are all in the brain stem, not high in the high ends of the brain, but down lower in the lower ends of the brain stem, where the trigeminal sensory nucleus is, the nuclear being the beginning point of a nerve that goes then to the trigeminal motor nucleus and then to the spinal trigeminal nucleus and back to the muscles that move the temporomandibular joint. This same mechanism is the exact same mechanism that operates the elbow, which is similar disease, almost exact same disease, which is tennis elbow. This is the same mechanism that works on the knee, where your muscles that get tight, that move the knee, get tight when you have a, excuse me, when you have inflammation within the knee. It's the exact same mechanism, and this mechanism has been discussed and written upon since 1906. The orthopedic surgeons are well familiar with this mechanism. I began to be familiar with it when I did my orthopedic rotation, and one of my colleagues said, "Tony, you need to learn about joint splinting." And he used the example of tennis elbow, and how tennis elbow is nothing more than the elbow being splinted by the muscles of the forearm that move the elbow. When you have inflammation of the lateral epicondyle, it sends a signal to the brain stem. It says, tighten the muscles, don't move the joint. We're going to help you. We're going to help you get that joint to heal by not moving the joint. And the muscles of the forearm get tight. That's called tennis elbow. and the muscles of the forearm get tight, and the muscles aren't hurting. The muscles pull on the periosteum, the covering of the bone, and in the covering of the bone are the nociceptors, these receptors that create the pain. So the muscles get tight, they pull on the periosteum, stimulate the nociceptors, and that goes back to the brain and is actually registered as pain. Well, that's the exact same mechanism that works for the temporomandibular joint. And I have spoken on this mechanism, written on this mechanism, but it's not my mechanism. It has been out there for quite some time. And let me see if I can bring up a diagram that I posted a little earlier that talks about the earlier papers that have been written on this. This mechanism that I did not discover. I just read on it, was introduced to it, read about it, and applied it to temporomandibular joint problems. TMD is not multiple disorders. It's one disorder. And I just described the mechanism, and it is written upon all the way back to 1906, where C.S. Sherrington wrote on the integrative action of the nervous system, Yale University Press. This is the reflex muscle splinting of joint inflammation and established physiology. This is established knowledge. And why the dental profession tries to avoid this is beyond me. I don't know why they don't want to look at this material, but this particular Saturday's presentation, I'm going to make an effort to bring it to as many people's attention as I can. It also goes on to many other scholarly papers. The orthopedic bone physiology literature has Hurley, M.V. Hurley, Manual Therapy, 1997, discusses it. J.T. Hopkins and Ingersoll in Journal of Sports Rehabilitation in 2000 discusses this reflex muscle joint inflammatory system. It's even written on in articles in the Journal of Oral Rehabilitation and Journal of Orofacial Pain by Cecil, and even the Journal of Orofacial Pain by Wang, Arndt, and Nielsen. All bring to the attention of this same mechanism that explains why there is only one temporomandibular joint disorder, and it all originates with chronic inflammation in the joint. If you can decrease chronic inflammation within the temporomandibular joint, you have solved the problem. And so we have. And hopefully over time, we can get around the doctors who try to make this a multi-specialist problem with claiming that literally it is as many as 30 separate diseases, which is not. It's one disease. It's one disorder, chronic inflammation within the temporomandibular joint. So what I want to do today, what I wanted to discuss today was what I had done in 2019. I traveled to Washington, D.C. and participated in the consensus study on temporomandibular joint that was originated and put together by the National Academy of Sciences, Engineering, and Medicine. It was a very interesting meeting. I actually have a copy of the written report on this entire meeting, and it was attended, people were invited, scientists were invited from all aspects of medicine and dentistry and the basic sciences to get their heads together to address and discuss, first of all, why there has not been a unified solution for temporomandibular joint. That's what they were there to discuss and to find out how they could get on with studying it, what they needed to study to find a solution to the problem. And that was 7 years ago. That was 2018. So what I hope to do is I had a presentation at that meeting, and I'm going to begin that presentation. It's a short presentation, and what I did was an attempt to bring to the attention of this esteemed body who were there to ask the questions, first of all, why there has not been more progress on temporomandibular joint disorder, and what they could do about it to study it further to actually find the answers. That was their purpose. And after a year, they published this book, which was entitled Consensus Study, Temporomandibular Joint Disorders, Priorities for Research and Care. Priorities for Research and Care. So I did an attempt to give them a priority to look at, which was chronic inflammation. Spoiler alert, after 7 years and a thorough read of this text, my attempt failed in getting anyone at those tables to address or even look into or begin further research on chronic inflammation within the temporomandibular joint, as I have not discovered, just read the articles and applied it to temporomandibular joint problems. So I'm going to play this. I was only given 5 minutes to speak. I have to say it is 7 minutes, but I think it's worth looking at to, again, I go over the material, I go over my attempt to bring it to the attention of these researchers as to what they needed to look at. So here we go. We'll play this, and then I'll have a few comments at the end. And while we play this, if there are any people online who would like to ask questions, you can put them in the chat. When this finishes, I'll be able to answer your questions. I encourage you to ask questions. I encourage you to fact check me if you'd like. I encourage you to criticize if you'd like. I'll be happy to respond to criticisms because I have the knowledge, the basic knowledge and the broad knowledge of this problem. So let's watch what my presentation was, and after that, I'll address any questions or comments that come up on live chat. Thank you. I come to you this afternoon after a long day, which is very enlightening, as a patient advocate, a researcher, and a provider. Thank you for allowing me the opportunity to address the committee. My purpose is to direct the committee to an area of investigation that I have found productive. My name is Anthony Urbanek. I received my dental degree and master's degree in anatomy and cell biology from Indiana University and my medical degree from Vanderbilt while working toward a PhD in anatomy cell biology. In 1976, I was awarded a 2-year fellowship from the NIDCR, then known as the NIDR, for my self-directed study to induce reproducible temporomandibular joint craniofacial anomalies in an animal model by way of laser-induced intrauterine fetal surgery. After completing this study in my internship and residency in oral and maxillofacial surgery at Vanderbilt, I have spent the last 40 years in private practice in Nashville, having performed over 2,000 surgical procedures on the temporomandibular joint, half as open procedures and half as arthroscopic procedures with varying degrees of success and failure. I believe I am well qualified to comment on the current research, treatment modalities, and provider training for the amelioration of the symptoms of TMD. 10 years ago, after applying all my surgical skills and knowledge to the conundrum of TMD, and because of the less than predictable results, I decided that I could not, in good conscience, recommend surgery as the solution for the enigma. I had a burgeoning practice of patients, mostly females, showing up at my door requesting help, but I would now have to turn them away. Because of my broad background in the sciences and independent research, I decided instead to create my own study and ignore the myriad of congresses, textbooks, lectures, articles, and recommendations of colleagues from the many disciplines involved with the TMJ. I decided to instead apply the guiding light of my career. If one cannot find a solution to a problem, he is either asking the wrong questions or asking the wrong people, or both. So began a study by collecting data from the actual source with a very simple process. I began sitting with my patients and asking them and encouraging them to tell me everything they could about their symptoms, their history, and their problem with TMD. Many of them, at least half of the cohort, which was 12 out of 24, many of them repeated a similar comment. If I place a pencil eraser, my tongue, my finger between my front teeth and gently bite down, it feels better. After hearing this multiple times, the light bulb ignited, and I thought, I wonder what will happen if I make a device that fits between the front teeth and that it can be worn for 24/7. I constructed such a device and gave it to one of these patients who had symptoms for 20 years, asking her to keep it in her mouth 24/7, taking it out only to eat, and return in 3 weeks. 3 weeks later, much to my surprise, she said her symptoms were all gone. Then I applied this strategy to another patient and another and another. Not everyone had 100% of their symptoms subside after 3 weeks, but everyone had substantial improvement and continued to improve over time to the point of wearing the device limited to nighttime only. After treating 30 or 40 patients in this manner, I knew the anterior occlusion, disoccluding the posterior teeth, was effective, but I had no idea how it worked. None. What were the anatomic, physiologic, pathologic, neurologic mechanisms at play that allowed a simple device that only occluded the anterior teeth and disoccluded the posterior teeth to have such a profound effect on relieving the symptoms of TMD in patients who had suffered symptoms for 10, 20, or 30 years? The next step consisted of what Albert Einstein euphemistically called thought experiments. For sake of brevity, I only have 5 minutes. I will give you the factual findings in bullet form. 1, every TMJ patient I operated on had inflammation as the consistent common denominator in the first line of the pathology report of the mandatory tissue sample. In other words, the common denominator of all TMJ problems in my practice was inflammation. 2, 90% of the loads on the temporomandibular joint are from the posterior teeth. This fact has been validated by many, many dental studies. 3, and the centerpiece of my remarks and the understanding of the conundrum and the route to a most viable solution is this. Inflammation within the temporomandibular joint stimulates an autonomic response from the central nervous system to contract first the muscles of mastication, then the muscles of the neck, then the muscles of the shoulder girdle to hold the TMJ immobile in contradistinction to the constant mobility of the joint in normal function and bruxism. This mechanism, well known to our colleagues in the orthopedic literature, explains muscle trismus in tennis elbow, but is conspicuously absent from the dental literature relevant to trismus of the muscles of mastication in TMD. Conclusion. Unloading the temporomandibular joint in a defined manner to offset the continued and unavoidable loading of this joint will predictably alleviate inflammation within the joint and associated symptoms of TMD. Using this protocol, I have successfully treated over 2,000 patients in the past 6 years who continue to report amelioration of symptoms using the devices prescribed. Therefore, I respectfully recommend to this committee focus on evidence-based research and methods for unloading the temporomandibular joint while maintaining normal daily function as a superior way to treat symptoms of the TMD.
Thank you.
Thank you.
Gary Bulow, followed by Vincent DeFabio.
All right, so that was a 7-minute presentation. 7-minute presentation to the National Academy of Sciences Engineering on March 28th, 2019. That was my attempt to bring this to the attention of the profession, all the profession, especially dental profession, as an oral and maxillofacial surgeon who had decided that temporomandibular joint surgery was not going to be the long-term solution to the temporomandibular joint problem. Frankly, I surprised myself when I began to do the basic research that was described on this, which was described in the last 7 minutes, how it was successful. Then I had to figure out how it worked, what was going on, and the rest is what has occurred in the last 15 years, which is using a device which is now patented, FDA cleared, independent university studied and approved and certified as accurate, statistically proven. And on the other hand, after 7 solid years and a year to produce this tome, consensus study, no further action, no further research to my knowledge, and I'm happy to be corrected, is being done on chronic inflammation as the cause of all of the symptoms, which I just described. So we need to get out of a rut here. We need to get the profession, the dentists, the dental professions, the dental schools to look at my independent, simple research as a starting point to solve this problem. If anyone else can come up with a better idea, a better successful mechanism other than unloading a temporomandibular joint with a device that you have to be able to chew with, because the protocol is just as important as the device itself. You can't just put a pencil between your front teeth, because you can't hold it there for 24/7 for 2 months and nighttime only the rest of your life, because that is the protocol. You have to have a device designed so that you can wear it long enough. You can speak with it in your mouth. You can breathe with it in your mouth. You can drink liquids with it in there. I actually designed this in such a way based on all of my work doing cleft palate reconstruction, bone grafting and cleft palate reconstruction, many other kinds of oral and maxillofacial reconstructive procedures where I had to use oral devices which were independently constructed so the patient could chew in addition to having surgery, either while surgery healed or while in preparation for whatever surgery was going to happen. And so that experience gave me enough knowledge to know how to create a device that you could speak with, you can breathe with, you can drink with, and you just have to take it out of your mouth when you chew. So this is the state of art in March, now 7 years later. Now we're May of 2026, and there's still no known science going on specifically for studying chronic inflammation, creating all of these symptoms, all these disparate symptoms, except the study that I have, which I'll be happy to share with anyone if they'd like to comment and like to talk to me about this. So we've gone on for about 30 minutes since I started this. I know we have some viewers here. I appreciate those who have signed up and viewed my presentation here Saturday, May 2nd, 2026. And if you have any further comments or chat, now's the time to get it. Otherwise, I'm just going to wrap this up. I know that we track people who view the live stream after it's published, and there are many more people who watch it actually after it's published than there are on live stream. So seeing no comments, seeing no questions, seeing no criticisms, I am going to just end it for today. Encourage anyone who wants to learn more, or if you are a dentist, if you are a doctor who would like to learn how to treat TMD non-surgically with a very simple device and protocol that is just super effective and proven by academic independent statistical study, FDA cleared. You can see more at www.urbanek.com. Anyone who'd like to comment or contact me can be done at my email address. Happy to give it to you. Tony, Tony, at tmjservices.net. With that said, we'll wrap it up for this Saturday. I look forward to the next time that we talk, which hopefully will be next Saturday. I'll pick on a related topic, which usually springs into light in the following week after I do a podcast, a live stream. I look forward to you returning. I look forward to questions, comments, and for the time being, I am Tony Urbanek, and this is TMD Demystified live stream.